welcome Dr. Holdridge.
Thank you everyone for joining us this evening. And Molly, thank you so much for sharing your story. I think it is really important for providers as well to hear the other side of it, because so often we can say all these things, but until you hear a patient's perspective of it, it really kind of changes how we deliver information as well. So in an ideal world, preconception planning would be done, but with nearly 45% of pregnancies being unplanned, this is not always possible. I really, I think with Molly's journey, she was able to really come up with a plan. And I think, again, that's the ideal situation, but that's not always possible. And as Molly had shared with us that research has shown that despite possible improvements, the majority of patients with migraine, 1 in 5 or 20% of women with migraine avoid pregnancy because of concerns that the migraine will get worse or the migraine may affect the health of their child or both. And as a neurologist, I frequently will get referrals for patients who feel completely abandoned. I've had a handful of people who have come to me that have said, as soon as I told my neurologist that I was pregnant, they were pretty much hands off. And they said, you have to come off your medications. Good luck with that. And that's really heartbreaking because pregnancy is anxiety provoking. And then when you add the layer of migraine disease on top of it, it certainly puts us all in a precarious situation. And it doesn't have to be that way. We have various options, whether they choose to be pharmacologic options or non-pharmacologic, that we can certainly help guide patients through this journey, and that it can be a more joyous journey, if you will. So my goal for this presentation is to examine the natural course and the natural progression of migraine throughout pregnancy. And I think many women with migraine are surprised to learn that in the majority of women, not everybody, but they do improve throughout that journey. We'll take a look at some red flags, some things that we shouldn't just dismiss as another headache or another migraine. We'll look at what creates a solid foundation for lifestyle and behavioral hygiene, and look at what are the acute and preventive treatment options that are available, and how do we decide what is appropriate, and how do we really weigh those risk and benefits. And then we'll conclude by looking at some interventions. Molly had mentioned a few with trigger point injections and some of the others that we do have available to us, as well as some of the devices that are new to market that are frequently used. So next slide, thank you. The first trimester can be very difficult for all women, even those who don't suffer with migraine disease, because certainly we're plagued with nausea and extreme fatigue. I think I lived my first trimester on saltines and ginger ale. But it's not always going to be that way for the whole journey for many women, not all. Data has showed us that 50% of women improve by the end of the first trimester, 80% will improve by the second. And a question I often get asked is, well, how do I know what camp I'm going to be in? Because if you told me I'm going to improve, then it makes my decision for pregnancy maybe a little bit easier. But unfortunately, we can't really predict that. Data has shown that those of us who do experience aura, or that transient neurologic sign, may be less likely to improve. However, those of us who do have migraine that's more focused around our menstrual cycle may be more likely to improve. So next slide, please. It's certainly important to know your body, like Molly had said, and any change from a typical headache is certainly a reason to contact your provider. Another red flag would be, and those of us who experience aura, anything that's atypical with the progression. Most patients with migraine disease who do experience aura, it's a stereotyped progression. So anything that's outside of that norm would be a red flag. And interestingly, it's not uncommon for women to suddenly develop aura during pregnancy. A retrospective hospital-based study found that actually 70% of women who reported migraine with aura had no previous history of aura. But if you've never experienced aura, this is certainly something to mention to your provider. If you were to experience a thunderclap, and by that we mean an intense onset type headache that's explosive in nature, this is not something that you want to just wait and use your patient portal for. This is a medical emergency that needs to be addressed. Headaches that may be associated with fever. Certainly fever is our body's way of telling us that we're fighting an infection, and we want to make sure that we're not dealing with something such as meningitis that may also be associated with headaches. Positional component. With this, we typically mean patients who prefer to be flat, and then when they sit up or change positions, it immediately exacerbates their pain. And this can be a sign of a low pressure headache, as opposed to those patients who prefer to be standing and upright, which may be more indicative of something more ominous within the brain itself. Visual disturbances certainly can be part of aura, but if you were to have any new visual disturbances, any prolonged visual disturbances, I saw somebody recently who had what we call persistent visual snow or double vision. That would certainly be something that we need to be addressed. We want to make sure that blood pressures are not getting high, because that can be another sign of preeclampsia. And certainly any new onset neurologic sign, whether it's weakness on one side of the body, new onset seizure, sensory loss, difficulty swallowing with coordination. These are all urgent signs that you want to contact, again, in an emergent situation, not message your provider on the portal. And as far as workup goes, a lot of patients are surprised to learn that non-contrasted MRIs can be performed with little risk. CT scans and gadolinium contrast, however, are typically avoided. Next slide, please. At the foundation of migraine is really lifestyle and behavioral techniques. And I like to use the mnemonic SEEDS, which stands for sleep, exercise, eating, diary, and stress. And I frequently will use the analogy of a house. So if your house has a strong foundation, whatever stressor may be, whether it's gale force winds from a hurricane or an earthquake as a stressor, that house is going to stand. But if you have cracks in your foundation, if you have those same stressors, your house is likely to fall. So we really want to work on creating a strong foundation, and really underlying that is sleep. And I trained with Dr. Merle, and I still hear her voice telling patients migraine brains like routine and regimen, going to bed, waking up at the same time every day. So consistency is really the key there. Exercise has proven physical and mental health benefits in the treatment of not only migraine, but also chronic pain. Tai Chi is something that has recently been studied as well, which are gentle meditative sequences of movements that can help with mental focus and breathing. For those of you who are Peloton fans, they have a new prenatal series that's out that's very exciting as well. Eating and diet, certainly, again, while we want to reach for those saltines and those ginger ale, anything to kind of get us through, we want to make sure that we're trying our best to incorporate a healthy diet. Tracking through a diary, whether it's a mobile app on your phone or with pen and paper, is certainly helpful to identify any triggers that may come about. And then stress. So stress is one of those innate things that we need in our life. It's something that creates our fight or flight response that identifies a danger. But when we have added stresses of family and work and all of these things that weigh us down, it certainly can become overwhelming. And next slide, please. So how do we deal with some of those things? Well, behavioral modalities can certainly help to empower us, as it helps us to learn our body's response to pain and adapt to the understanding of head pain and be more proactive in our approach, and can also help with other pregnancy-related issues such as insomnia, anxiety, depression, and stress. Biofeedback and relaxation techniques And a study showed that 45 to 60% reduction in headache intensity and frequency with proper and regular use. Digital cognitive behavioral therapy, again, there's lots of apps on your phone, which all of us have readily accessible most of the day, have also been shown to be beneficial. Acupuncture has been studied for pregnancy-related conditions, morning sickness, depression, insomnia, and a systemic review did show some benefit as well with migraine. Physical therapy added to pharmacologic treatment or any nutraceuticals or whatever other modalities can certainly be helpful at reducing headache frequency and disability. I'm a huge proponent of dry needling, especially if there is a cervicogenic component. And this is typically an extra certification that's done through physical therapy. Most needlers tend to avoid first trimester, but second and third trimester, finding somebody who's comfortable with needling can be very beneficial. Next slide, please. Treatment is important. That's why I think I get so frustrated when patients come to me and say that they've basically been abandoned by their provider and just left to figure things out, because everyone deserves a rescue therapy plan, because we know that not treating attacks can lead to more frequent and more refractory attacks. And certainly if we're nauseous and vomiting, we're going to become dehydrated and our electrolytes are going to deplete, and we're just going to create a vicious cycle. Treatment is also important to help us get to work. And that would be not being at work absenteeism, but this new concept of presenteeism, which I think a lot of us kind of grin and bear it when we're there if we're suffering a migraine attack. But the concept of presenteeism is you're physically there, but cognitively, it may take you 3 times as long to get that project done, or you just may feel cognitively foggy with it. So you're physically there, but mentally, you're not really there, if you will. Next slide, please. So it's not uncommon for women to be hesitant of pregnancy for fear of having to come off previously effective medications because of safety concerns. A recent study found that 90% of people with migraine attacks report using complementary and integrative medicine to treat migraine. However, there is a misconception that all nutraceuticals are safe during pregnancy, and this is certainly not the case for some of those evidence-based nutraceuticals that we use in the times that we're not dealing with pregnancy. Next slide, please. So how do we determine what's safe and what's not safe? Clearly, it's not ethical to do trials in pregnant women. So up until 2014, the FDA had given us a set of pregnancy guidelines that you can see are A through X that helped to guide us. However, they were felt to be a little bit misleading, and since these have been dissolved. Unfortunately, there's been no replacement, and instead, clinicians, we've been advised to substitute our understanding of available evidence. So although the letter system has been dissolved and many of us find that it's obsolete, in order for people to be on the same page, you may hear some of these pregnancy categories talked about or come about. Next slide, please. So as I mentioned, everyone, regardless of frequency, certainly deserves reliable acute rescue for an exacerbation of a migraine attack. And the goal here is to really restore function, to resolve our pain, resolve disability, with the goal of 2 hours. But no medication is completely without risk, so these need to be weighed with potential benefit. And I know Molly had said acetaminophen, and I think a lot of us gravitate towards acetaminophen because it's something that notoriously has been thought to be one of the safer options. And certainly it's still considered more safe. There's a little controversy, however, that has come about. Some of you may have heard from the Agency for Healthcare and Research and Quality that did a systemic review that showed an increased risk of early childhood respiratory disorders with frequent use, and reports of prolonged use and third trimester use leading to attention deficit hyperactivity disorder. So while the data suggests that more frequent use may increase some of these risks, it may be reasonable to use them occasionally, certainly to help treat attacks. Going down the list, cyclobenzaprine is a muscle relaxer that's commonly used, especially if there's a cervicogenic component that is considered more safe. Diphenhydramine, also called Benadryl, is often combined with an antiemetic or anti-nausea called metoclopramide. And then as far as triptans go, traditionally triptans have been avoided during pregnancy because of potential concerns for problems with placental circulation. However, given how common triptans are, we now have pregnancy registries in which patients who have been using triptans who found out they were pregnant, that we do have data on that has been collected. So while many of us would argue that triptans are certainly not first line, they tend to be a lot safer than some of the things that you see lower down on the list that are unfortunately often handed out way too frequently and way too high of amounts, in my opinion, such as butabitol and opiates such as oxycodone. Next slide, please. There are agents that we really want to make sure that we avoid. And the gepants, and by that I mean rimegepant and dabigatran, that have really kind of changed the migraine landscape. We just don't have enough data at this time to say that they're safe during pregnancy. So maybe in 10, 15 years, hopefully we'll be looking back on this and having a different opinion. But for this point in time, those are certainly rescues that we would recommend stopping, as well as lasmiditan, which is a new ditan. Ergot, such as dihydroergotamine, is an old medication that we've known for a number of years that is contraindicated and certainly would need to be stopped. Next slide, please. Not everybody needs prevention, and certainly given the natural progression that we see in many patients with migraine attacks during pregnancy, it may not be needed, but there are certainly situations that they are. And choosing a preventive, we often try to choose one that can also treat comorbidity. So if you also have hypertension during pregnancy, we may opt for a blood pressure medication that may also help with kind of kill two birds with one stone, if you will. Magnesium is something that is very commonly used in the oral form. However, the safety of it has some controversy, and this dates back to 2013 when IV magnesium, which was used for eclampsia, was changed from a category A to a category D due to problems with fetal skeletal abnormalities when it was used for more than 5 days. However, does this translate to the oral formulation? We really haven't been able to get a sound answer, even when this was brought up to the FDA. So I would say the majority of headache specialists continue to use the oral formulation throughout pregnancy. Now, onabotulinum toxin, also known as Botox, the official stance is that it's not recommended during pregnancy. However, there are certainly situations, like in Molly's case, that is justifiable, if you will. And I am somebody who does inject during pregnancy because, again, I've seen how debilitated many patients can get when we do stop Botox. So in my clinical practice, this is something that if a patient has already shown benefit with it, it is often something that we continue once we discuss the risk and benefits of Botox in pregnancy. With that. Next slide, please. As far as preventives that we want to avoid, the new CGRP antagonists that have come to market, erinumab, frenemizumab, galcanezumab, eptinezumab, all those that they made really easy to say and roll off your tongue, as well as rimegepant that was approved for prevention recently, and atogepant. Those are things that we would want to stop just because of lack of data. And a quick comment on the first four, those are what we call monoclonal antibodies, and these stay in our system for a long time. The half-life, or how long it takes to break down, is anywhere from 27 to 31 days, but to be completely out of our system, it can be up to 6 months. So in those who are thinking of pregnancy, we would recommend be off these agents for at least 6 months, but certainly that's not the case. We're not able to do that with everyone. Topiramate, lisinopril, candesartan are other agents we want to avoid. Feverfew and Butterbur. So those are nutraceuticals that are found in a lot of combination pills, supplements, and these are certainly things that we would want to avoid. The Feverfew due to premature uterine contractions, and Butterbur has been linked to fetal abnormalities. Next slide, please. The interventions and non-oral procedural options certainly can be beneficial for a lot of our patients. As you know, Molly had told us her experience with occipital nerve blocks and trigger point injections. I'm actually going to jump 2 slides to go to that. So if you wouldn't mind fast forwarding 2, and then we'll come back to the interventions. So a trigger point is an area in the muscle belly that's exquisitely tender. In patients with migraine disease, we frequently see trigger points in that cervical paraspinal region, trapezius, rhomboids. And what is typically used is lidocaine, which is a long-acting numbing medication, which is injected into these areas of exquisitely tender areas in the muscle belly. We typically do not use Kenalog, which we will often use. It's a steroid in patients who are not pregnant. The data on whether or not Kenalog affects how long it lasts for is another controversial thing that many of us have our own opinions on. But either way, in pregnancy, we do not use Kenalog with it. Sphenopalatine ganglion blocks. So this dates all the way back to the 1900s, where they used to take really long Q-tips and dip them in cocaine and stick them up our nose, not our nose, but people's noses back then, to block this collection of nerves that lives behind our nasal septum that we know is active in migraine and cluster headaches as well. So there are a few devices that are on the market, but there's also some really easy home techniques that can be taught as well to do it at home. Peripheral nerve blocks, I would say occipital nerve blocks are the most common, and typically would use that long-acting numbing medication, lidocaine, to prevent that pain synapse in that occipital region. So that would be in the back of the head. That picture in A is what's being done there. Also, auricular temporal nerve can be targeted, as well as our supraorbital and supratrochlear, which are above the eye. And then we'll go back 1 slide to neuromodulation. So I think neuromodulation is really cool. It's a little wacky, and it's a little difficult, I think, to conceptualize. And at this time, we have no clinical data for pregnancy, but I would say many of us are utilizing them quite frequently in patients who are pregnant. So the first one, the transcranial magnetic stimulation, is that top left picture. And what you do is you take this device and you put it on the back of the head. There's a button that you push and it administers a pulse. And the thought behind it is that it's decreasing or increasing the threshold of activation and decreasing how those signals are propagated. Vagus nerve stimulation is the picture on the right. This was initially approved for cluster headache, but it has been cleared for migraine prevention and rescue. And you simply put it against your neck that stimulates the vagus nerve. It takes about 90 to 120 seconds to do. Transcutaneous neurostimulation is the the little device on the forehead over there, which has been cleared for both rescue and prevention. And the goal there is stimulating the trigeminal nerve. And then we have remote electronic neuromodulation, which would be the armband. That's that second picture on the right. And the goal there is to inhibit the pain pathways by activating the descending pathways to inhibit that propagation of pain response. And then the last one is the multi-channel brain neuromodulation. This is also called the Reliance device, and I was fortunate to be part of the initial launch with this. And it's a headband that can be worn, and a lot of our patients are seeing some really good benefit and relief with it. So then we'll fast forward to 2 more slides down to the summary with that. So again, many patients with migraine will improve during pregnancy, as Molly had shared with us, though that's not always completely reassuring for everyone. It's easy for us to say, but as a patient, it certainly can be anxiety provoking. Pre-pregnancy planning is of course ideal, but not always something that can be done. And as a reminder, if a migraine headache or any neurologic symptom is different from something you're not used to feeling, that's certainly something that you would want to contact somebody about. Cognitive behavioral therapy, mindfulness, yoga are helpful modalities to incorporate into any treatment plan. Good headache hygiene, creating that solid foundation, is imperative. Not everyone needs prevention, but everyone, again, should have access to reliable rescue tools. And remembering that not all nutraceuticals are safe, but certainly with any treatment modality, we need to weigh the benefits with potential risks. And asking about neuromodulation, devices as well as procedural interventions that can be used adjunctively can certainly be helpful in all of our toolbox to come up with a plan to help guide patients through their pregnancy journey and to help make it as positive as possible.